Good afternoon, everybody. Welcome to the session on implementation and measurement to improve health systems. My name is Elizabeth McCarthy. I am the Director of Applied Analytics at the Clinton Health Access Initiative. And I'm co-chairing this session with Dr. Sevgi Aral, who is a Scientific Director at the US CDC in the Division of STD Prevention. So it's my pleasure to introduce the first speaker, Emmanuel Krebs. Emmanuel Krebs is a health economist at the BC Centre for Excellence in HIV/AIDS. He'll be speaking today on the health resource use pattern analysis to inform targeted interventions alongside the HIV cascade of care and optimize the effect of treatment as prevention. Thank you.
Thank you very much. Oh, that's loud. Hello. So my name is Emmanuel Krebs, as was mentioned, as a health economist at the BC Centre for Excellence in HIV/AIDS. And I'd like to thank the scientific committee for giving me the opportunity to present today on my birthday. Yes, thank you. I'll be presenting health resource use pattern analysis to inform targeted interventions alongside the HIV cascade of care to optimize the effect of treatment as prevention. Get the formalities out of the way and declare that I have no conflicts of interest. So the UNAIDS 90/90 targets are explicitly driven by the HIV cascade of care model. And while the cascade is a well-established population-level monitoring tool of care engagement, individual experiences tend to be complex. For example, Hal and Needham have dubbed what they call the side door of individuals initiating ART, antiretroviral treatment, without being first retained in HIV care. As another example, our group has recently found heart persistence to be a recurrent event process. We indeed found frequent interruptions lasting greater than 30 days. And while as the duration on heart decreased the probability of cessation, subsequent periods on heart tended to become shorter. And the median time spent off heart was approximately 2 months. So achieving the 90/90/90 targets is going to require longitudinal continuous retention in HIV care. And therefore, looking at the longitudinal health resource utilization patterns of those lost to the cascade can help us inform strategies to achieve these ambitious targets. So starting here with, as the denominator, the individuals linked to care, this simplified cascade model shows the subsequent steps of retention in HIV care, heart receipt, and virological suppression, which is the ultimate goal of the cascade of care. And while over time some individuals will be continuously engaged and retained in care, there are some individuals, when we look at their status over time, where we're going to see some variation. And these people are the people that are going to be intermittently engaged in care. These individuals are a heterogeneous group, where some individuals will be engaged in care once and then lost, and other individuals will cycle in and out of engagement. The two highlighted groups are going to be the focus of my talk. So we conducted this study in order to identify and characterize health resource utilization patterns of people living with HIV/AIDS in order to inform the development of targeted interventions to effectively increase retention in the cascade of HIV care. We considered all adults linked to care in BC, where we defined linkage to care as a HIV-related physician visit or heart dispensation following diagnosis, and excluded all individuals linked to care prior to September 2006. Since we wanted to look at longitudinal patterns, an inclusion criterion in our study was having 3 years of follow-up, hence our final study sample was composed of 1,078 individuals. We used linked comprehensive health databases in British Columbia, a setting in which by now you would have heard multiple times provides universal access to all care and HIV care. We defined 4 quarterly HIV variables and 5 non-HIV indicators. The statistical analysis we conducted was a probabilistic model-based clustering analysis. And the intuition behind this procedure is an attempt to group individuals together that are more homogeneous within their cluster than to individuals that are found in a different cluster. And the membership to these clusters is the parameter that is being estimated by maximum likelihood using the expectation maximization algorithm. This being a model-based analysis, the optimal number of clusters was determined by the Bayesian information criterion. So, as I previously noted, these are the 2 subgroups of interest for our talk, and we now have here 2 groups that are homogeneous in terms of their longitudinal classification of intermittent engagement in care. So we have those that have intermittent retention in HIV care, which was composed of 189 individuals, roughly 18% of our sample, and those that had intermittent heart persistence. And again, that was defined as individuals having at least 1 episode of greater than 30 days off heart. And that subgroup was composed of almost 1/3 of our study sample. So the results for those that had intermittent retention in care, the optimal number of clusters we found for this subgroup was 2, with a distribution of individuals that was roughly 1/3 and 2/3 across the clusters. We see that both groups had practically no engagement in HIV care, and in non-HIV care, cluster number 2, the smaller cluster, had 4 times more physician visits, 10 times more non-heart prescription medication days, and this resulted in a total cost that had a ratio of 6:1. Further characterizing cluster 2 was a high prevalence of injection drug use, a high prevalence of mental health resource use, thank you, in the year prior to linkage, and also a high prevalence of hepatitis C. Now, looking at the results for the second subgroup, again here analysis concluded as having 2 clusters being the optimal number of clusters, but here we had a more even distribution between clusters with 43% and 57% respectively. Very little HIV care engagement, non-HIV care engagement that was 2.5 times larger for cluster 1, 8 times more medication days for cluster 1, and this resulted in total cost that had a 5:1 ratio for cluster 1. So what characterized this cluster, cluster 1, that had the higher cost? Well, the median time to initiation was much greater in this cluster, even though time to linkage and median first CD4 values were equivalent across groups. Furthermore, we saw higher hospitalization costs. These are median costs for the clusters. And as previously in the high-cost cluster, there was a higher prevalence of injection drug use and hepatitis C as well. So what does this mean? Well, we see that in both subgroups, we found 2 distinct health resource use clusters. One was characterized by an active involvement in non-HIV care. And then we saw another one that had little or practically no interaction with the healthcare system as a whole. And what our results suggest is the need for differential intervention strategies in order to target all of these individuals. For the people that have an active involvement in non-HIV care, it's really about seizing missed opportunities. Here we have the opportunity to integrate HIV care for physicians that are already in contact with these individuals. And for example, at the BC Centre for Excellence, we're going to be launching an intervention this fall that's called the Extended HIV Care and Opioid Substitution Treatment, which is a cluster randomized, a staggered cluster randomized trial of which we'll be conducting the effectiveness and cost-effectiveness evaluation. Now, for those that have little or no interaction with the healthcare system, we really need to be targeting these individuals more directly. And one way, one example, is engaging physicians delivering HIV care. And again, at the BC Centre for Excellence in HIV/AIDS, we launched a province-wide intervention in 2015 that does just that. So when individuals are either heart interrupted or taking a little bit too long to initiate treatment, there's an alert that goes out to their HIV physicians to inform them of this delay or interruption. And if their status doesn't change at any time between 60 to 120 days, then there's a more active public health intervention that occurs in order to really try to engage these individuals. So these are just preliminary ideas that we're working with, but there's still more opportunity for more targeted interventions. And for example, once we start looking in a more granular fashion at the specific medications being prescribed, or the more detailed characteristic of the physician visits, or the physician characteristics themselves, we will have even better ideas for more targeted interventions. In closing, I'd like to acknowledge and thank all the individuals and institutions that have made the Stop HIV/AIDS study group possible, as well as all the other activities of our research group. Thank you very much.